Hello, everybody. It's a great pleasure for me to introduce Professor Stefano Gasparini to be here in Thessaloniki. Nikos Kufos, welcome.
Hello, Professor Gasparini. I apologize also like to you that I'm not able to be there. There was a last-minute change. It is my great pleasure to see at least Professor Gasparini online.
Let me say a few words, because I need a lot of words to introduce you the Professor Gasparini, who is a professor in Ancona, but also he's a director in a specialty medical school. He's also a director of the postgraduate master in interventional pulmonology, and now he is the chair of the World Association of Bronchology and Interventional Pulmonology. You make so much, and you do a lot of things. We have the pleasure to hear you a lot of times, many years. But it's the first time in Thessaloniki. It's a great pleasure and honor for us. Please.
Thank you very much, everybody. Good evening. It's my pleasure to be here. It's really the first time that I am in Thessaloniki, not in Greece, because I was a lot of time in Athens, but I was here for the first time, and I had the opportunity to enjoy this town this afternoon. That is wonderful, and I would like to come back again in the future. Well, Dr. Dipopoulos asked me to talk about trends in interventional pulmonology training. What are the European perspectives? It's not an easy topic because, you know, training is different from site to site, and there is no standardized way to teach interventional pulmonology. There are a lot of points to be discussed. Well, this is my conflict of interest disclosure. The first thing is that we know that to learn interventional pulmonology, we require additional training and expertise beyond that required in a standard pulmonary medicine training program. There are people that finish their specialization in pulmonary disease and that never have a bronchoscope in their hand. It happens in Italy, but I think it happens everywhere. So additional training and expertise. We have some questions to answer. To whom should we provide training in interventional pulmonology? Where to provide training in interventional pulmonology? And how do we provide additional training and expertise in interventional pulmonology? The first question, to whom? The components of the training in interventional pulmonology are a lot, as you can see. There are theoretical knowledge of pulmonary anatomy, of pulmonary physiopathology, understanding imaging, basic knowledge of cytology, of smear cytology, knowledge of clinical pulmonology, and so on. You can read on the slide all the components, the theoretical components that young people, that want to perform interventional procedures should know. And the last and the most important is that together with all these theoretical components, there is the development of manual skill. All these theoretical components are acquisible by all the pulmonologists, no problem. Take a book, take an atlas, study, and for sure, in some months you will be proficient of a lot of these things. But the problem is the development of manual skills. The development of manual skill requires three components. The first one is acquisible, is practice. Everybody can practice on model, on human being, everywhere. But there are two components that are not acquisible. The first is the individual natural bent to perform some interventional procedure. I know a lot of pulmonologists, very good pulmonologists, that don't want to perform interventional procedure. They don't like to do it. They like better to study COPD, to study pharmacology, to study aerosol, and they don't like to perform intervention. And the other one is passion, that also is an individual attitude, because interventional pulmonology, in most of cases, don't make you rich, don't allow us to gain money. So you need to have a passion and individual natural bent, because you know, out of 2 guys, even after a life of training, will never become Bocelli or a singer. Well, I performed a lot of hands-on courses, and I realized that there are people that learn immediately, that have a natural bent to perform procedure. They will be proficient after few procedures. There are others that require some more time, some more procedure to become proficient, but there are also other people that will never learn to perform bronchoscopy or to perform interventional procedure, even after months and months of practice. Well, another factor that, in my opinion, is very important is the age. Interventional pulmonology procedure should be learned by young people. You know, you haven't never seen, probably you have seen people who play tennis or people who ski. Well, you immediately recognize if these guys have learned to ski or to play tennis as young, or if they have learned to play tennis in an old age, because automatic reactions, muscle memory are acquired at a young age. So, in conclusion, to whom do we provide training in interventional pulmonology? Young colleagues with passion and with a predisposition to manual skill. And not all the pulmonologists have this requirement. Where to provide training in interventional pulmonology? This is another very important point. Where? We should identify teaching centers where there is high volume activity. And this teaching center should be certified by the scientific society. One of the aim of the Interventional Pulmonology Society, we have here Grigoris, that is president of the European Association for Bronchology. I'm now chair of the World Association for Bronchology. We should work together, Grigoris, because in my opinion, this is one of the most important points. The scientific society should certify what are the center, the teaching center. But here there is another problem, because few centers perform all the procedure at high level. I know a lot of interventional pulmonology service that are excellent in diagnostic bronchoscopy, but not in thoracoscopy. Some other perform thoracoscopy, but not bronchoscopy. Some other are excellent in IBUS technique, but not in rigid. So probably the scientific society should identify different centers, and the fellows should attend different centers to complete their educational pathway. Each training center should provide a list of the techniques that in that center are performed at high level. And this is most important. How to provide additional training and expertise? There are several ways. You are lucky. Young people, young pulmonologists today are lucky because you have a lot of possibility. Internet, if you are going to Facebook, you can find a lot, or Facebook or YouTube, you can find a lot of movies with all the different interventional pulmonology techniques. So you are very lucky. Because I remember that when I was young, when I started, I had only one possibility, to move the head of my chief and to put my eye in the small hole that was the lens of the bronchoscope. But what happens? That I put my eye here and my chief say, hi, I have to work, so remove your head and finish. Just a few seconds to realize. I could only figure out what happens into the airway. Today you can see everything, and this one was one of the most important progress that the endoscopic technique had in the last decades. The possibility to have a camera, the possibility to have video scope, the possibility to take pictures, to take movie, to digitalize what you are doing and to diffuse everywhere. And this is a huge progress, maybe one of the most important progress that interventional pulmonology had. There are several hands-on courses. In Europe, for instance, I should remember a lot of courses on bronchoscopy that are organized in Athens by Grigoris. There are ERS courses on thoracoscopy in Marseille. We also organized interventional pulmonology courses in Ancona. In my life, in the last 20 years, I organized about 80 courses. And Grigoris was probably one of the first fellow a lot of years ago, and then he became teacher of these courses. He was a lot of time involved. There is also a program to teach IBUS TBNA organized by the ERS, and again Athens is involved, Ancona is involved together with Heidelberg and Amsterdam for this program. But 2-3 days courses are not enough to provide skill, even if there is an hands-on practice in these courses, but in my opinion, 2-3 days are not enough. So we, in Italy, try to organize something more. A postgraduate master in interventional pulmonology was organized in 2 cities, in Florence and in Ancona. And what is a postgraduate master? A master degree is coming from Latin, magister, is an academic degree made by a university or college that provide a course of study that should give to the participant mastery or high-ordered overview of a specific field of study or area of professional practice. Well, the Italian experience is quite interesting in this field. The first one who started was Lorenzo Corbetta in Florence that organized the first edition in 2009-2010. We arrived later. We did the fourth edition of the Master in Ancona, but with the experience, as I told you, of more than 80 courses. This is an old slide, more than 80 courses that had 650 participants coming from 10 different countries. Well, what is the problem? The problem is the cost. The cost of this master is quite high. University want to be paid for organizing these courses. The cost of the Florence or the Ancona master is about 3,000 euro for the participation. And you can see that the participants were not only pulmonologists, but also thoracic surgeons, but also people that probably are not the best people to participate, because I don't know what an anesthesiologist can learn from a master. An anesthesiologist should manage the bronchoscope, just to intubate patient, to remove secretion and stop. And this doesn't require mastership. Internal medicine, first aid, ear, nose, throat. But the most serious things is that requiring money, we have few young people. And you can see that the mean age of the participants is quite high. 43 years is the mean age. That means that there are people that are older than 40 years. And as I told you before, young age is one of the requirements to become proficient in interventional pulmonology. This is a nice table because we can see that there are a lot of women, female, that participate at these masters. So that this means that there is a growing interest for women to perform interventional pulmonology. And this was not the same in the past. How is the master organized? The master curriculum is 1 year of activity with 1,500 hours of didactic that are divided in 130 hours of frontal lessons, seminars, 685 hours of alternative didactic. That means live cases. These people should follow live cases directly in the bronchoscopic suite, in the endoscopic room, or through a system of video. And also an individual study, 685 hours of individual study on literature, books, and slides of the theoretical frontal seminar. Plus, we require also 2 weeks of frequency in a qualified high-volume interventional pulmonology service. And this curriculum ends with the final examination and the thesis discussion. You can see here some picture of Florence and of Ancona master. You can see here Grigoris, Daniela Gompelman, Hervé Dutot, Palavsa, Najib Rahman, and this is Lina Zuccatosta, that is my first co-worker, and now she's director of the interventional pulmonology unit in Ancona. Well, hands-on can be done on low fidelity models, low fidelity simulation. You can see here some model. You can find these tool everywhere. There is more plastic model of the airways, and there is a model that can help you to practice for intubation and to use rigid scope. But there are also high-level, high-fidelity simulation model, is simulator, where you can also learn a lot of things, and especially, for instance, this is very important for HIBUS, for the knowledge of anatomy, but also for some tools of samples like needles or like forceps. And another problem is that these simulators are quite expensive, but it's very, very important to have it in a teaching center. Live cases is the most important aspect of our master. For instance, in Ancona, participants observed the 50 cases, and this is data of 2021-2022, of diagnostic, therapeutic bronchoscopy, HIBUS, rigid bronchoscopy, cases of bronchoscopic lung volume reduction, bronchial thermoplastic at the time, percutaneous needle biopsy, thoracoscopy. You can see my friend Pietro Marchetti with Lina Zuccatosta that are performing a thoracoscopy. You can see here a transbronchial approach to peripheral lesion. So you can see a lot of such cases with all the consequence of a live procedure, because participant can see complication, can see some problems that could happen during live, and it happens in a bronchoscopic room. The light that turn off, for instance, where you have your bronchoscope inside the airway, what you should do, or bleeding, if it happens, what you should do. So live is, in my opinion, live cases is, in my opinion, the most important way to show how the procedure have been performed. And the individual study, there are platforms on internet. This is the platform of Florence. You can see here all the different things that you can see on this website, and this is our website of Ancona. And there is also the literature and the slides of all the theoretical lessons that have been done. We divided in Ancona our master in 10 integrated courses, just to identify the topic we are talking about: introduction to interventional pulmonology, anatomy of airways, general aspect of procedure, sampling techniques in central airways, peripheral airways, mediastinal lesion, interventional pulmonology and infiltrative diffuse lung disease and lung cancer, pleural pathology, disobstructing bronchoscopy technique, bronchoscopic treatment of chronic obstructive pulmonary disease, interventional pulmonology and infectious disease, pediatric bronchoscopy was also evaluated, and interventional pulmonology in the critical care unit and emergency. And all these courses evaluate not only the interventional procedure, but also the clinical context in which the interventional procedure are included. And this is very important. This is one of the reasons why I don't understand, because surgeons perform interventional pulmonology in some centers. It's okay for cancer because surgeons know very well cancer, but they don't know the clinical context of infectious disease. They don't know the clinical context of infiltrative lung disease, diffuse infiltrative lung disease. They don't know the clinical context of chronic obstructive pulmonary disease. So this is one of the reasons why I'm convinced that interventional pulmonology is a branch of pulmonary disease specialty. There is also the final evaluation. We use a multiple-choice questionnaire with 10 questions for each integrated course, evaluation on simulator to evaluate the skill assessment, and a final master thesis that will be proposed by each participant with review of bibliographic data or clinical case description, what they want to do. Where master is an important educational step that can provide the additional training that I mentioned at the beginning of my talk. Interventional pulmonology requires additional training. So master is a good step. A good step not only for people that would like to become interventional pulmonologists. One of the major problems that we have in Italy, I don't know if it happens also in Greece, is that a lot of pulmonologists don't know the possibility that interventional pulmonology has. So what happens? Look at this case that should be avoided. These are two patients that were sent to us by a surgeon, and this patient were sent to surgeon for diagnosis by pulmonologist. This means that those pulmonologists didn't know or didn't want to know that is possible. What are the possibilities of bronchoscopy that can easily solve and reach the diagnosis of these two cases? But pulmonologists send these cases to surgeons. And this is the end of our specialty. We cannot cry because surgeon, because allergologist, because infectious disease specialist, because internal medicine invade our field of competence. We cannot cry if we are the first to send to other specialists cases that can be sent to pulmonologists. Of course, master is most important for colleagues that want to become interventional pulmonology, but is not enough. These pulmonologists must continue their educational program with long time attendance. I think 6 months, 1 year is necessary in a high volume IP service. So pulmonary fellow, these are the steps, pulmonary fellowship, master or courses, but it should be completed with attendance for a long time in a high-volume IP service. And as told my friend Atul Mehta, my mentor and my friend Atul Mehta, when he finished all his presentation, he had the slides that say, "I'm still learning." And Atul Mehta is more or less, has more or less my age, so he is still learning. We are still learning, and the practice in an hospital, in interventional pulmonology, should endure all the life. Don't forget passion. Passion is a very important component, and I like this slide. Yes, okay, I'm still learning. This is the mention of Atul Mehta sentences. I like this picture because I like music. I play some instrument, and I know that practice is a very important thing, but also passion is very, very important. So you should use your bronchoscope like a musical instrument. Practice every day, and know every day what is your environment, what is your music. This is the final pictures because all the master ended with a dinner. That is very important, and this is people that attended the Ancona master. Here you can see some teacher. This is Venerino Poletti, the friend, and this is the Florence master. I hope that some things in my talk are clear, but I know also that there are a lot of doubts or problems still to be solved to standardize in a universal way the pathway of education in interventional pulmonology. Thank you very much.
For this discussion, which is realistic and pragmatic, and it's the same problem here in Greece. Nikos.
Hi, Nikos.
Hello, Professor. Congratulations, and I would like to say also a big thank you for all the lessons we've learned by you and all the inspiration. And I have a question for you, but I would like to give the microphone to my dear colleague, Dr. Vίτσας, who is a commentator. So if we could start with comments, if Stavros, you agree, and then we can jump to questions. I don't know.
Do we have no comments and no questions for now? Please do.
Okay. Greetings from Athens. I am Vlasis Vίτσas. Apologies for not being able to be there. I don't know whether you can hear me. Congratulations for the excellent talk, Professor Gasparini. I don't have a question, but my comment is that my generation is very lucky, and I'm optimistic because you had the big problem achieving and standardizing everything in IP pulmonology, and we had the opportunity to taste the fruits of your success and be part of all the seminars and the IP training. Having Professor Stratakos as my mentor was a gift, and it was accomplished due to my participation in one of the first IP training interventional programs for ERS. I didn't expect it to be that eye-opening for me, and of course I agree that in 2 or 3 days it's not much you can learn, but you can taste the feeling of IP pulmonology, learn what is going on, and then stick to it, and with years of training, saying that you can be a little bit of IP pulmonologist, not like you, but studying still every day. Thank you for contribution, for you, for Professor Stratakos, and all the courses that young lads can participate now these days.
Thank you very much for your comment. Thank you.
Professor Stratakos, do you
Grigoris, you are called a lot of times, so you must.
Thank you very much, Stefano, for this nice talk and for your presence here, which gives honor to all of us. And I also thank you for the lessons I've taken from you, because you were my first inspiration with your work in Ancona, not only because you were an expert in bronchoscopy and interventional pulmonology and you were so good teacher, but because you were in Ancona. You were not in Rome, you were not in Paris, you were not in Berlin, you were not in New York. You were in Ancona, a relatively small city in Italy, which was not so, you didn't have all the benefits that you would have in a big university, in a big capital of Europe, but you managed with your work and with your persistence to create a tradition there and make Ancona known for you and for your work. And this is really a big lesson and inspiration for us. That means that we can achieve a lot of things if we're working closely together and we are working well and with persistence. And I owe that to your work, and I wanted to tell you even in public. Apart that, I would like to make two notes, 2 comments I would like you to discuss. First of all is the American experience of fellowship. In the States, there are many programs of fellowship, as you very well know, and these are 12 months duration. And the pulmonologists who want to take this subspecialty or to gain this fellowship are working there and are paid instead of paying. So they are working like we do in all subspecialties, like we do in oncology, like we do in infectious diseases subspecialty, or intensive care unit subspecialty, and so on. So after their main fellowship in pulmonology, they are deciding, and after some tests, they are accepted and work for the subspecialty, so they have the opportunity to gain the needed experience. So this is the American paradigm I would like you to comment on. And the second is the ERS paradigm of accreditation of each one of the modalities. Accreditation for IBAS, accreditation for thoracic ultrasound, accreditation for rigid, or I don't know, maybe later for BLVR and so on. So this is another solution to separate each modality. We use each procedure and create a course with simulation possibilities, with validated assessment tools and training tools with which we could accredit the doctors for each one of the procedures, and then if someone wants to take all the procedures, he can build a log book with all these accredited procedures. That's the other way to do it. Thank you for your comments.
Yeah, thank you for your nice words that are a little bit hard for me, because if I learn to you, and you was one of my fellow, this means that I'm very old. So, well, concerning the American experience, my honest opinion is that the American certification that is done by the American Association for Bronchology and Interventional Pulmonology is a little bit a business. I don't think that in America interventional pulmonology is very well known and is performed at the same level that in Europe. This is my idea, because they have a lot of money, they have a lot of technology. But for instance, I read now a lot of paper from people that use robot or robotic bronchoscopy. You know that robotic bronchoscopy means 3,000 euros of disposable material for procedures. And they show very nice cases, but they show also cases that can be very easily solved with our traditional means. I saw some presentation of robotic bronchoscopy from American guys, and they show some nodules that probably you and me were able to sample with less expensive means. And this means that these people did not receive a good training in traditional interventional procedures. So, in any case, we have to follow the American pathway, because I think that at the end we will arrive to certificate also in Europe such competence, and probably we will not have money to pay this guy, but I think that is one of the way that in the future should be. And another thing is that the evaluation. We know what happens. I don't know in Greece, but in Italy, what happens? The evaluation. Perform the procedure on the model and let me see what you are able to do. And when you are looking at this guy that is doing the procedure, I receive a phone call from his mentor, that is my friend, and say, hey, look at, this is my fellow, this is my friend, please avoid to take off from the certification. You know, I don't know if it happens in Greece, but I'm sure that it will happen in Italy. for sure. So probably in USA they have a more objective and rigid modality of evaluation. That means also, after 1 year of training, to say to somebody, my friend, you are not able to perform the procedure. You are not, and this is not easy in our Mediterranean area or in our mentality, you know? Well, this is the first thing. The second thing is the certification of teaching center should be, in my opinion, easier. Just require how many procedures do you perform? What are your results? What kind of procedure are you doing in the center that want to be candidate to become teaching centers? And this is easier, but I don't know why we are talking about this topic for a long time. I remember that we started to discuss about 10 years ago on the high-end teaching center, but we have not yet reached the target. We have not yet a list of certified centers. And probably, I don't know if ERS is the main, I think that maybe the European Association for Bronchology that is more, is a small society and there is less bureaucracy and less difficulties that are very, very hard in the ERS to be solved. I think that it could be one of your idea and your program. I cannot do as World Association because the World Association is difficult to standardize different situations, China, Japan, US, South America, Europe. There is some confusion, but Europe maybe can concentrate and you can make an effort to finalize this identification.
Professor Gasparini, thank you very much for all the inspired talk.
Thank you.
Dr. Κουφός and Dr. Vίτσας, thank you for being a member of this talk. Everybody, thank you for being there.